So thank you so much to BRCA and BC for this opportunity to speak to you today about something I focus a lot on, which is pancreatic cancer risk and management. And in particular for BRCA individuals, tonight we'll hopefully be able to answer some of the questions that you might have had, and I'm looking forward to the Q&A later. My name is Cremin, and as you've heard, I'm a genetic counselor at the Hereditary Cancer Program at BC Cancer. I also work in a special research arm called the Familial Pancreatic Cancer Program. And this program's mission is to reduce the morbidity and the mortality of hereditary and familial forms of pancreatic cancer. So just acknowledging that I live and work on the unceded traditional and ancestral territories of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations. So for the outline today, I will be presenting some background information on BRCA and pancreatic cancer risk. I'll review a bit about the role of the pancreas, the current pancreatic cancer rates, risk factors, and treatment. And we will focus on evidence for pancreatic cancer screening in the BRCA population, as well as recommendations for our BC patients. We will then review some of the methods you can choose to reduce your own risk, and have a question and answer period after. I should start by really underlining that this is a rapidly evolving area. What we are reviewing today may change in 6 to 12 months. So it is important to check back either with the Hereditary Cancer Program or with your healthcare provider for updates in this area. I'm hoping by the end of the session today, you'll have a bit more context around these questions. Should I consider pancreatic cancer screening? When should I start? What protocol is recommended? And what additional measures can I take to reduce my risk? So BC was actually one of the first programs or locations in all of Canada to be able to offer genetic testing across the board to all patients newly diagnosed with pancreatic cancer, regardless of their family history or their age of onset. And we've really learned a lot since that time about the importance of integrating genetic testing into their care and into the care of families for cancer risk assessment, treatment, and prevention options. And it's now a standard of practice for pancreatic cancer patients across many jurisdictions. So in BC, we have a mainstreaming pathway that facilitates this. Non-genetics providers are able to order genetic testing for patients newly diagnosed with pancreatic cancer. This could be oncologists, surgeons, even family doctors. If someone with pancreatic cancer was not able to access or undergo or did not have genetic testing, it's important for their close relatives to consider doing this themselves, and they can opt to be referred to the Hereditary Cancer Program. I recognize that many of you in the audience will have completed genetic testing and you have experience kind of going through this process, but there might be some in the audience who haven't yet had genetic testing, and I wanted to spend a minute on this today. So our bodies are made up of billions of cells, and each of these cells has our genetic information, 23 pairs of chromosomes, one copy of each pair from mom and one from dad. We have approximately 20,000 genes or instructions that are lined up on these chromosomes like beads on a string. And genetic testing involves reading out the genetic code, the A's, C's, G's, and T's that you see in these colored bars here of the DNA double helix. Genetic testing is looking for any errors in the sequence of this DNA code. And certain errors are what we call pathogenic variants. We used to call them mutations. We now prefer the term pathogenic variants. And these are, there's convincing evidence that these stop the gene from working properly, and they increase our risk for certain diseases such as cancer. Sometimes genetic testing can find variations in our genetic code that we don't understand well today. That's different. Those are called variants of unknown significance, and we cannot use those to assess risk or make recommendations. So today I'm really focusing on what we call the pathogenic variants that have a clear risk and management implications in BRCA1 and in BRCA2. So we know that BRCA1 and 2 are an important cause of hereditary pancreatic cancer. These are just 2 out of our 20,000 genes. BRCA1 is on chromosome 17, BRCA2 is on chromosome 13. And you can see here again, we've got 2 copies of each of these genes. They are tumor suppressor genes, so their role is to protect us from developing cancer. They actually repair DNA damage using a special pathway called DNA recombination repair pathway. And on the image on the right, you can see that in one cell, there's been a break in that DNA double helix. And there's a somewhat complex schematic there of what would happen inside that cell to repair the DNA damage. And you can see there's different gene products involved, including BRCA1 and BRCA2. And without functioning copies of those genes, a cell can accumulate more and more genetic damage. And that can eventually lead to tumor formation and to subsequent cancer. This table reviews the most current cancer risk estimates as provided by the National Cancer Comprehensive Network, or NCCN. The NCCN is a set of American guidelines, and this is a nice table because it gives a range of estimates based on different studies. The first column here is showing the cancer type. The second column is showing the population average risk for that particular cancer. The third column is showing the lifetime risk for a BRCA1 carrier. And the fourth column is showing the BRCA2 lifetime risks. Whereas BRCA1 and BRCA2 are very well-known, strong genetic risk factors for breast and ovarian cancer, they are considered moderate risk factors for pancreatic cancer. The risk for pancreatic cancer is estimated to be up to 5% for BRCA1 carriers and up to 5 to 10% for BRCA2. Some recent prospective studies following people with BRCA1 and 2 carriers over time have estimated somewhat smaller estimates and maybe a bit more precise, 1 to 4% for BRCA1 over our lifetime and 3 to 5% for BRCA2. But again, there have been different ranges with different studies. What this does mean, though, is that there's over a 90% chance that a carrier will not develop pancreatic cancer over their lifetime. The actual risks, of course, depend a lot on other things, including family history, other genetic risk variants, and environmental risk factors such as smoking, and even precursor lesions that might have been detected on screening that could have an impact on our risk. The same pathogenic variant can have a different impact for different people in the same family. This is called variable expressivity in genetics. And BRCA1 and 2 also have something called incomplete penetrance. Again, this is the notion that people can have the pathogenic variant, but not develop any cancer over the course of their lifetime. Having a family history of pancreatic cancer has generally been the cue to offer pancreatic cancer screening to BRCA1 and BRCA2 carriers. And this is because expert groups believe that those were the patients most likely to benefit from screening. There aren't any tools yet that can combine the impact of both a pathogenic variant and a family history, but this is an active area of research so that we can get more personalized risks in the future. So we know that in total, about 10% of pancreatic cancer does have a hereditary basis. BRCA1 and 2 are what we're focusing on today, but there are a handful of genes, 11 in total, that do cause a hereditary risk for pancreatic cancer, and some of them have a much stronger risk than BRCA1 and 2. As opposed to the hereditary category, we understand that about 20% of pancreatic cancer is what we call familial or multifactorial. We might see a few cancers of the pancreas clustering in one family, but genetic testing is normal. We don't find one of these major high-risk genes, and we feel that in those families, it is likely a combination of other genetic susceptibility factors as well as environmental susceptibility factors. So extra screening may still be recommended for some families, even if they don't have one of the major hereditary pancreatic susceptibility genes. Most pancreatic cancer, by far, is sporadic. This is typically age-related. There is not a strong role for inherited genetics in sporadic pancreatic cancer. And in these families, the risk is likely not significantly higher than the general population. So just a little bit about the pancreas. It is a small but very important organ located behind your stomach in the upper part of your abdomen. It sits very deep inside the body, tucked between the stomach and the spine. It's about 6 inches long and shaped somewhat like a fish with a head, a body, and a tail. It has two really important roles, a digestive role, and also a role in regulating blood sugar. So the pancreas produces enzymes like amylase, lipase, and protease that help break down the food that you eat. And these enzymes are released into the small intestine where they digest carbohydrates, fats, proteins. Without these enzymes, your body wouldn't be able to absorb nutrients from food. The pancreas also produces hormones, the most well-known being insulin. And insulin helps control the amount of sugar or glucose in your blood by allowing your cells to take in glucose for energy. The pancreas also makes glucagon, which helps release glucose into the blood when it's too low. If the pancreas doesn't work properly, it can lead to problems like difficulty digesting food or conditions such as diabetes. The part of the pancreas that's associated with that pancreatic duct you see in the middle of the pancreas, the light green duct, and the acinar cells that you see clustered in blue and in green, these cells kind of in the pancreatic body and tail. These have other functions, of course, but most pancreatic cancer is in the endocrine pancreas. Sorry, I should flip that around. Most cancer is in the exocrine pancreas, like you see on the slide here, about 90%. But about 10% of pancreatic cancer is in the endocrine pancreas. And that's specifically those blue clusters of cells there where the hormones are produced. And at this point in time, we don't see a strong correlation between neuroendocrine tumors of the pancreas and BRCA1 or 2. The association is more so for these exocrine cancers. And the type of pancreatic cancer we consider mostly in this kind of relationship is pancreatic ductal adenocarcinoma. And for short, we call that PDAC. So risk factors for pancreatic cancer. We know that 1 in every 75 Canadians will develop pancreatic cancer over their lifetime. The average age at diagnosis is 71. Age is a very important risk factor. The vast majority of individuals are diagnosed over the age of 60. Cigarette smoking is a well-known risk factor. It doubles the risk, and it actually is higher in the heaviest smokers. Interestingly, risks can decrease to that of non-smokers 10 to 20 years after smoking cessation. So there is always a good reason to quit smoking. Diabetes for more than 5 years or long-standing diabetes is a risk factor, about doubling the risk for pancreatic cancer. Men are slightly more at risk than women, but it's not a huge difference. Nutrition can play a role. A diet high in red and processed meats is thought to increase the risk, whereas a diet high in fruits and vegetables may decrease the risk. Obesity and heavy alcohol use have been associated with an increased risk for pancreatic cancer. And pancreatitis, which is a chronic inflammation of the pancreas, can cause tissue damage over many decades, eventually leading to cellular damage, DNA damage, and an increased risk for pancreatic cancer. Some ethnic groups have a higher background risk, including the African American group. And then precursor lesions can also increase our risk for PDAC or pancreatic cancer. In particular, something called intraductal papillary mucinous neoplasms, or IPMNs for short, pancreatic intraepithelial neoplasia, or PANNs for short, and then a type of lesion called a mucinous cystic lesion of the pancreas, or MCN. Most of these do not progress to cancer, but they are a risk factor that may require additional follow-up and sometimes surgery. Just a little bit more about the association between pancreatic cancer and diabetes. It's a very active area of research. It can be diabetes, both a risk factor and also a symptom of pancreatic cancer. Research is showing that new onset diabetes in people over the age of 50 may be an early symptom, especially in the setting of weight loss. Several studies have observed that individuals, again, older than 50, with this new onset diabetes have a 0.5 to a 1% risk of being diagnosed with pancreatic cancer in the following 3 years from their diagnosis of diabetes. The majority of people diagnosed with new onset diabetes do not develop pancreatic cancer. So there is a very strong interest in trying to use new onset diabetes along with other profiling of that population to identify what risk factors to help that might help with stratification. These are just the numbers from the Canadian cancer statistics showing predicted numbers for 2024, highlighting that pancreatic cancer is the 11th most common cancer in Canada, affecting about 3,800 males, which you see in the blue bar here, and then just on top of that, about 3,300 females. But the graph below is showing that pancreatic cancer is the third leading cause of death, and that is after lung cancer and colon cancer. So this really emphasizes the urgent need to improve not only treatments and options for patients with pancreatic cancer, but to really focus on early detection to identify cases at the earliest stage. So unfortunately, signs and symptoms of pancreatic cancer usually do not appear until the disease is advanced. And this can include weight loss, changes in stool, abdominal pain that might radiate to the back, nausea and loss of appetite, and of course jaundice, which is this yellowing of the skin and the whites of the eyes. The 5-year survival across all stages of pancreatic cancer is 13%. What this means is that at 5 years, only 13% of patients are still living with their disease. And only 1 out of every 5 patients are detected early enough where surgery is an option, so they can be treated with that surgical intervention. In that group with early stage pancreatic cancer or localized disease that are eligible for surgery, the 5-year survival is remarkably higher at 44% compared to a very low 5-year survival when it's detected at a late stage. So surgery, radiation therapy, chemotherapy, these are all treatment options that may extend survival or relieve symptoms. What's interesting from a BRCA1 and 2 perspective is that genetic status can help with treatment selection, and pathogenic variants in BRCA1 and BRCA2 are associated with an increased sensitivity or responsiveness to platinum-based chemotherapies. The other interesting thing to note is that in clinical trials, a drug called a PARP inhibitor has improved progression-free survival in patients with metastatic BRCA-related pancreatic cancer. And this image is just showing how these new tailored treatments might work, maximizing the vulnerability of BRCA-related pancreatic cancers with that homologous recombination repair problem because of the role of BRCA in the cells. So we do believe that early detection is the key to improving outcomes in pancreatic cancer, and this is a very, very active area of research. Early detection could be things like imaging, for example, screening tests like endoscopic ultrasound and MRI that we'll talk about a little bit more. But it can also be artificial intelligence, so machine learning from prompts or from symptoms in electronic medical records. Biomarkers are a very interesting area, things like circulating tumor DNA in the blood or multi-protein panels that might be able to identify risk before symptoms appear. And radiomics is an advanced field of medical imaging that involves extracting a large number of quantitative features from these medical images to analyze different characteristics, tissue characteristics, size, shape, intensity, to reveal an underlying cancer that may not be visible to the human eye. At this point, I should state that only imaging has been incorporated into routine kind of clinical practice, and research is underway to try to incorporate all of these elements to increase the sensitivity and specificity of screening programs. And we'll talk a little bit more about the PRECEDE consortium later, which is a pancreatic cancer early detection consortium that we are fortunate to be part of in British Columbia. So pancreatic screening, as opposed to colon screening, breast screening, cervical screening, pancreatic cancer screening is not recommended for the general population, the average risk individual. And in fact, in 2019, it received a D grade recommendation from the United States Preventive Task Force after reviewing all of the evidence. And this means that the potential harms outweigh the potential benefits. And the reason for that is this is a low prevalence disease. So you would be doing potentially a lot of unnecessary tests for a relatively small number of cases. There are also limited screening tools that are not highly effective, although might have some success. They can be limited in asymptomatic individuals. There's a high mortality rate for some groups, even with early detection. And there are, of course, potential harms in screening, like false positives, anxiety, unnecessary invasive procedures. However, the general consensus from different expert groups and current guidelines is that pancreatic cancer screening should be offered to individuals who are at increased risk because the risk-benefit ratio may be more favorable. And what is that increased risk? What do we mean by that? Most guidelines define it as greater than a 5% lifetime risk for pancreatic cancer. A little bit more about the methods, these imaging methods, endoscopic ultrasound or EUS and MRI. So in an endoscopic ultrasound, sound waves are used to create images of the pancreas that are viewed on a computer monitor. In this test, an echo endoscope is a thin tube attached to an ultrasound probe, and that is placed in a person's mouth after sedation and advanced through the esophagus down to the stomach near the small intestine where the pancreas can be viewed. EUS is performed as an outpatient procedure under anesthesia. Magnetic resonance cholangiopancreatography, or MRCP, uses MRI, which is a non-invasive procedure that produces computer-generated cross-sectional images of parts of the body. So after being lightly sedated, the patient lies in a cylinder-like tube. The technician injects dye into the patient's veins, which helps to show the pancreas, the gallbladder, and the pancreatic and bile ducts. At a baseline consultation with a GI specialist, a gastroenterologist, it's really important to have that discussion about pros and cons of each approach, any contraindications to the approaches, and to discuss what's available in the area, what is the expertise where I am. Any imaging that is performed ideally should be performed in an experienced clinic that does a high volume of pancreatic screening. And given the uncertainties of screening, participation in research is strongly encouraged by almost all guidelines, because what we need to do is evaluate the impact and outcomes of this screening. So the guidelines, I mentioned they change quite frequently. Several organizations have issued various guidelines for people at increased risk of pancreatic cancer. And these guidelines caution that cystic lesions of the pancreas are not uncommon. So it's not uncommon to find something if you're screening the pancreas. And most of these lesions found on screening will not warrant biopsy, surgical resection, or any intervention. More long-term follow-up is needed to really evaluate the impact of the screening. But we do have some promising data from research groups internationally about some of the benefits. And this PROCEED group that I mentioned earlier, the current protocol, because there's not wide agreement on exactly what protocol to use, but PROCEED consensus is that annual imaging with alternating EUS and MRCP is the option kind of choice if it's available. So just quickly talking about the evidence and really just highlighting in the interest of time, two of the more recent studies that have a longer prospective follow-up period, more than 20 years, following high-risk individuals who were getting routine pancreatic cancer imaging done. One of these studies is from the Netherlands, and one of them is from the United States. And both of these studies showed very high rates of resectability or resection, so that the pancreas could be removed, the tumor could be removed because it was detected in early stage. And these studies both also showed encouraging long-term survival in the patients that had a screen-detected pancreatic cancer, as opposed to those patients who were detected or who were developed their pancreatic cancer off of any screening, so not a screen-detected pancreatic cancer. And just a couple points on the study. In the Netherlands study, there were about 340 carriers of a very high-risk pancreatic cancer gene, a more significant risk even than BRCA1 and 2. And in that group, 31 individuals developed pancreatic cancer. Those were compared to pancreatic cancers that were diagnosed in the general population. And it was seen that the stage 1 rate was 39% in the screened group, so that early stage diagnosis, whereas only 6% of patients were diagnosed with stage 1 disease in the non-screened pancreatic group. And the 5-year survival was 32% compared to only 4.3% in the unscreened pancreatic cancer group. And then just briefly in the US study, this was on 1,700 individuals getting regular pancreatic screening, either because of a family history or because they had a pathogenic variant in one of the moderate or strong risk genes. 26 cancers were diagnosed over that time period of over 20 years. 19 of them were detected in patients who were adhering to the regular screening, whereas 7 were detected in patients who weren't adhering to screening. And in the surveillance group, again, that stage 1 early detection rate was much higher. So bottom line about the screening, surveillance for pancreatic cancer in certain high-risk individuals is beneficial, and it does have a meaningful impact on disease course. Earlier detection, increased resectability, improved survival. But surveillance by imaging alone is a suboptimal strategy. By that, we mean it's definitely not perfect. There are diagnostic errors with false positives and false negatives. And even under surveillance, late-stage cancers are not uncommon. False positives can lead to unnecessary surgeries, and there can be some confounding in the way these studies are done with lead time bias and other kind of study design related matters. And so more research is needed to continue to measure the benefits and risks of screening. But I think there's wide agreement that surveillance needs complementary tools. So what we've talked about a little bit, biomarkers, blood-based screening tools, and artificial intelligence to really complement imaging that's available. So I have to thank my colleague, Dr. Trasolini, a gastroenterologist in Vancouver General Hospital, who's provided the GI perspective of kind of what are the key points that a gastroenterologist might discuss with a patient who's thinking about undergoing pancreatic screening. And these are really important pieces I wanted to share here as well. So endoscopic ultrasound and MRI have similar sensitivity. A benefit of EUS is it allows for biopsy of suspected lesions. It does require sedation, similar to an endoscopy, but it might be better for patients who have claustrophobia or metal implants. Dr. Trasolini also points out that MRI might be better for patients who just don't tolerate that kind of endoscopy type procedure. There is a small risk of missed lesions with both studies. Again, highlighting that kind of PROCEED protocol where we do recommend annual screening alternating between these two exams. Screening cannot reliably identify all precancers, but as you've seen in this previous studies I briefly reviewed, the likelihood of being diagnosed at an earlier stage is definitely there. And fortunately, for all patients, the benefit of a pre-screening consult is available. So really to have that personalized discussion about pros and cons with a GI specialist who is an expert in pancreatic screening. So let's focus on what we recommend for the BC context through our hereditary cancer program for our BRCA carriers. The first and probably most important point is that we believe patients should have annual diabetes screening. This can be a blood test once a year starting at 40. And we believe that any new onset of diabetes or unexplained worsening control of a previously well-controlled diabetes should prompt kind of more investigation or a referral to a GI specialist. If you have a family history of pancreatic cancer, we do recommend referral to a GI specialist, again at a high volume center with screening expertise to discuss the benefits and limitations of annual imaging. And in BC, we are fortunate that we have all 4 of these sites participating in PROCEED. So they are kind of our expert sites. So St. Paul's Hospital, Vancouver General Hospital, the Kelowna Gastroenterology Associates in Kelowna, and the Pacific Digestive Health Group in Victoria. Screening is recommended to begin at the age of 50 until typically age 75, and then it would be very much based on clinical status. Sometimes it's recommended that pancreatic cancer screening start earlier if there was a history of young pancreatic cancer in the family. So what about if we don't have any family history of pancreatic cancer and we have a BRCA1 or a BRCA2 pathogenic variant, and we saw that there is a moderate increased risk for pancreatic cancer, and it may be in that 5% range for BRCA1 and maybe in that 5 to 10% range for BRCA2. So we still think that, of course, being aware of diabetes, especially in the setting of weight loss, a new diagnosis of diabetes should prompt follow-up. Our hereditary cancer program at this time, reviewing kind of the literature at hand, is not routinely recommending that everyone with a BRCA1 or 2 mutation get referred to a GI specialist. But it's an area that we continue to follow, and some guidelines are evolving, in particular for BRCA2 and for individuals with an ATM, which is another hereditary risk factor, ATM gene, that even individuals without a family history in these moderate risk genes could consider screening. Again, really important for people without a family history to discuss things with their doctor in terms of benefits and risks. And if anyone is thinking about doing pancreatic screening, it is, of course, an option for them to be part of longitudinal research and follow-up, as you saw from prior studies internationally. So I mentioned earlier that British Columbia is one of the sites participating in the Pancreatic Cancer Early Detection Consortium and one of 3 sites in Canada. And this PROCEED consortium is a highly collaborative group. It's an international effort to improve survival of pancreatic cancer from the current 13% 5-year survival to over 50% in 10 years. It's a very ambitious goal. And the method for attaining that for this PROCEED consortium is by improving early detection, screening, risk modeling, and prevention for those with a heritable risk for pancreatic cancer. It is the largest effort of its kind, over 54 centers across the globe, 7,000 high-risk patients recruited so far who are being prospectively followed. And the goal here will be to establish practice standards for pancreatic screening and to develop and validate biomarkers that may help with early cancer detection, as well as artificial intelligence tools for screening. If you have a BRCA1 or BRCA2 pathogenic variant and a family history of pancreatic cancer, you can join the study by contacting our office. Our contact information is there. Participation involves 3 things. It involves completing an annual health questionnaire. It involves attending the annual imaging exam that your doctor referred you for. And it involves providing a research blood sample once a year that has to be drawn at Vancouver General Hospital. And that is because of the processing and the type of sample that's required for this novel biomarker research. But patients who are able to kind of think that they are able to participate in those 3 areas are strongly encouraged to contact us. The PROCEED research team does not organize the screening. Those screening tests are organized by your family doctor or your GI specialist, but it is a matter of sharing the de-identified information from thousands and thousands of patients that are getting screening in order to find trends and markers that we can then develop the best evidence-based guidelines for. And so far in BC, just showing you here where we're at, we have been inviting patients who are able to consent to that annual blood draw and annual imaging. We've consented over 100 patients so far. Many of them do have BRCA1 or BRCA2 pathogenic variants. Other genes as well are included in this study. And through this study, we're also able to get updates of kind of the most current evidence and research that's coming from these international groups of experts. Another study that BRCA1 and 2 patients might be interested in joining or thinking about is the CHARM study. And this is a biomarker study looking for early cancer detection using cell-free DNA. So cell-free DNA are short pieces of DNA that circulate freely in your blood. Most of the cfDNA in blood comes from normal, healthy cells, but cancer cells can also release cfDNA into the blood, and it looks different than what's released from healthy cells. Companies have started selling products that are somewhat related to this, but more research is needed to ensure that we understand the sensitivity, the specificity, and the recommended follow-up if you see a signal on this type of testing. But in BC, again, BRCA1 and 2 patients can join the CHARM study. They may be randomized to provide a blood sample 3 times a year for 4 years. And if you're in that study group, you will also receive results from the blood test. It does not replace any of the standard screening that we've talked about, and follow-up investigations would be of course needed if there was any positive signal on this research test. And you see the contact information there if you are interested in finding out more about the study. So going forward, talking about risk reduction, some of these things are self-explanatory, but they really do have an impact with pancreatic cancer risk. A lot of pancreatic cancer risk is attributed to these risk factors that can be avoided. So being a non-smoker is a really important step, or quitting smoking whenever you can, maintaining a healthy body weight, limiting alcohol intake, being physically active, eating a healthy diet. We talked a bit about limiting amounts of red and processed meats, and certainly talking to your doctor if you are concerned about any symptoms. And it's important to kind of stay in touch as well with your family history to know what else it might be in the family that could guide your screening recommendations. So some take-home messages from this talk is that genetic testing is a really important option for all pancreatic cancer patients, but also for those with a close family history. And we find BRCA1 and BRCA2 mutations or pathogenic variants in about 5% of pancreatic cancer, and it can inform treatment options. If you have a BRCA1 pathogenic variant, that lifetime risk is up to 5%, and in BRCA2, it's in that 5 to 10% range. Learn what you can about your family history. What really matters the most is first and second degree, so your close relatives. And if you do have a family history, referral to a GI specialist is recommended to discuss the pros and cons of screening. Ideally, again, at a high volume center under research protocols. And those without a family history of pancreatic cancer could still certainly discuss with their doctor kind of their own medical scenario, their own risks, other risk factors, motivations for screening to determine whether or not they want to take a step further with being referred to a GI specialist. But it's not a standard recommendation at this time from our program. It is important to talk to your doctors again if you have questions about whether pancreatic screening is right for you or about any of these other risk factors that we've talked about today. I've put a few links here We always recommend, as genetic counselors in the hereditary cancer program, to stay in touch with our program if family history changes or for the most up-to-date knowledge about gene-related risks and recommendations. If you're not already part of the Hereditary Cancer Follow-up Initiative and receiving annual questionnaires, you can sign up to get that. It is a great way to stay in touch with our program. And just want to acknowledge here that our familial pancreatic cancer program was established actually thanks to a very generous donation by the Bob and Judy Hager Family Fund, and also acknowledging the support we've received from these other organizations to continue clinical and research efforts in this area of hereditary and familial pancreatic cancer. I know some of my colleagues are here tonight from the Hereditary Cancer Program, and we really do look forward to hearing your questions. Thank you so much for your attention today.
Thank you so much, Carol, for that incredible information. Before we dive into the Q&A, I'll just maybe give Farhad an opportunity here to pause or stop this recording